This is the audio lecture for the postpartum period. This audio lecture will include a discussion of chapters 18, 19, 20, and 21. Chapter 18, Maternal Physiologic Changes. This lecture for Chapter 18 will focus on the anatomic and physiologic changes that occur in the mother during the postpartum period. The postpartum period is the interval between the birth of the newborn and the return of the reproductive organs to their normal non-pregnant state. This period is sometimes referred to as the puerperum, or fourth trimester of pregnancy. Although the puerperum has traditionally been considered to last 6 weeks, this time frame varies among women. The uterus. The return of the uterus to a non-pregnant state after birth is called involution. This process begins immediately after expulsion of the placenta with contraction of the uterine smooth muscle. At the end of the third stage of labor, the uterus is in the midline, approximately 2 centimeters below the level of the umbilicus. Within 12 hours, the fundus can rise to approximately 1 centimeter above the umbilicus. By 24 hours after birth, the uterus is about the same size as it was at 20 weeks of gestation. Involution progresses rapidly during the next few days. The fundus descends 1 to 2 centimeters every 24 hours. By the 6th postpartum day, the fundus is normally located halfway between the umbilicus and the symphysis pubis. The uterus should not be palpable abdominally after 2 weeks and should have returned to its non-pregnant location by 6 weeks after birth. Subinvolution is the failure of the uterus to return to a non-pregnant state. The most common causes of subinvolution are retained placental fragments and infection. This is figure 18-1 in your textbook. It's the assessment of involution of the uterus after childbirth. Picture A shows the normal progression days 1 through 9. B shows the size and position of the uterus 2 hours after childbirth. C shows 2 days after childbirth. And D is 4 days after childbirth. What I want you guys to notice is that in each illustration, we use 2 hands when we're palpating the fundus after delivery. You want to make sure you have a hand below the uterus to provide support, and then you have your hand here on top that actually pushes down to fill the fundus. The reason we do that is because we don't want to prolapse the uterus. So you always want to make sure you're supporting the bottom half of the uterus so you don't push it out through the vagina. Contractions of the uterus. Postpartum hemostasis is achieved primarily by compression of intramyometrial blood vessels as the uterine muscle contracts. The hormone oxytocin, which is released from the posterior pituitary gland, strengthens and coordinates these uterine contractions, which compresses blood vessels and promote homeostasis. Because it is vital that the uterus remain firm and well contracted, exogenous oxytocin, or pitocin, which I call vitamin P, is usually administered intravenously or intramuscularly immediately after expulsion of the placenta. So those of you who saw a vaginal delivery, if you notice whenever the placenta was released, the doctor would say the placenta is delivered, and the nurse would give the patient a bolus of the IV fluid with oxytocin. That's to make sure that the uterus contracts. Breastfeeding immediately after birth and in the early days of postpartum increases the release of oxytocin. which helps with blood loss and helps with contraction of the uterus also. After pains. In first-time mothers, uterine tone is good. The fundus generally remains firm, and the woman usually perceives only mild uterine cramping. However, in my moms who've had 2, 3, 4, 5, or 6 pregnancies, that uterus has been distended over and over again. And if you think of the uterus as a rubber band, you stretch it, it goes back. You keep stretching it, it doesn't go back as firm as it once was. So moms who've had several children, they typically will experience more afterbirth pains because their uterus has been stretched before. Also, women whose uterus was over distended, such if they had a big baby or a macrosomic baby, they had twins, triplets, quads, or they had a large amount of amniotic fluid known as hydramnios, they also will notice very painful afterbirth pains. Typically, if the moms are breastfeeding, they'll also complain of pain whenever the baby latches on, because we know that stimulating the breast releases oxytocin. So typically what we do for afterbirth pains is we give them 600 to 800 milligrams of Motrin every 6 hours. The placental site. Immediately after the placenta and membranes are expelled, vascular constriction and thrombosis reduces the placental site to an irregular, nodular, and elevated area. Endometrial regeneration is completed by postpartum day 16, except at the placental site. Regeneration at the placental site usually is not complete until 6 weeks after birth. Lochia is the post-birth uterine discharge. Initially is bright red. Typically the first lochia is rubra, which is the bright red, and I tell women it is going to resemble their menstrual flow. Lochia rubra consists mainly of blood and decidual and trophoblastic debris. The flow pales, becoming pink or brown after 3 to 4 days. Lochia serosa consists of old blood, serum, leukocytes, and tissue debris. The median duration of lochia serosa discharge is 22 to 27 days. In most women, about 10 days after childbirth, the drainage becomes yellow to white, which is lochia alba. Lochia alba consists of leukocytes, decidua, epithelial cells, mucus, serum, and bacteria. The lochia may continue for 2 to 6 weeks after the birth, but may last longer and still be normal. What you want to warn patients about is once they've gone through the lochia rubra, the serosa, then they're to alba, if they start back going to the lochia rubra, that means there may be a problem. So you have to teach the moms to make sure that they continue to watch the discharge, the lochia, once they're discharged in their home, to make sure that they're not bleeding too much. The cervix is soft immediately after birth. Over the next 12 to 18 hours, it shortens and becomes firmer. The cervical os, which dilated to 10 centimeters during labor, closes gradually. Within 2 to 3 days postpartum, it has shortened, become firm, and regained its form. The external cervical os never regains its pre-pregnancy appearance. It no longer has a circular shape, but instead appears as a jagged slit, often described as a fish mouth. The vagina and perineum. Estrogen deprivation is responsible for the thinness of vaginal mucosa and absence of rugae. Vaginal rugae reappear within 3 weeks. The vagina gradually returns to pre-pregnancy size by 6 to 10 weeks after childbirth. Thickening of vaginal mucosa occurs with return of ovarian function. Dryness and coital discomfort, known as dyspareunia, may persist until the return of ovarian function. Immediately after birth, the introitus is erythematous and edematous, especially in the area of the episiotomy or laceration repair. It is barely distinguishable from that of a nulliparous woman if lacerations and an episiotomy have been carefully repaired. Hematomas are prevented or treated early, and the woman practices good hygiene during the first 2 weeks after birth. So typically when we're talking about hematoma formation, usually it happens in a relatively short amount of time after delivery, and typically your patient will say, I have real bad pain in my perineum area. It feels like a baseball is between my legs. So the L&D nurse would do an inspection, and if she sees a hematoma on the labia, and typically they occur on the labia, we call the doctor in, and we take the mom to the operating room and do incision and drainage, and release the blood that's formed in the hematoma. And I'll talk a little bit about the hygiene, but I'll talk about that later in the lecture. But basically, after delivery, we give the moms a plastic water bottle, and every time they go to the bathroom, we have them fill it with warm water, and we tell them to squirt their bottom from front to back, and then take toilet tissue and just pat the perineum dry. Don't wipe or rub the perineum. Most of your episiotomies and laceration repairs are visible only if the woman is lying on her side with her upper buttock raised. That's why I say when I check the pads for lochia, I have them on their sides. That way I can see the amount of lochia drainage, and I can also see if they have episiotomies or lacerations that have been repaired. Hemorrhoids are commonly seen. Internal hemorrhoids can evert while the woman is pushing during birth. Women often experience associated symptoms such as itching, discomfort, and bright red bleeding. Hemorrhoids will usually decrease in size within 6 weeks after childbirth. But what we can do to make the mom more comfortable is use Tux pads or sitz baths to help with the perineal discomfort. Pelvic muscular support. The supporting structure of the uterus and vagina can be injured during childbirth and contributes to later gynecologic problems. Supportive tissues of the pelvic floor that are torn or stretched during childbirth can require up to 6 months to regain tone. Kegel exercises, which help strengthen the perineal muscles and encourage healing, are recommended after childbirth. The abdomen. During the first 2 weeks after birth, the abdominal wall is relaxed. It takes about 6 weeks for the abdominal wall to return almost to its pre-pregnancy state. That's typically when the woman stands during her first few days after birth, her abdomen protrudes and she still looks like she's pregnant. Typically, the skin will regain most of its previous elasticity, but as we've learned from earlier lectures, that striae gravidorum, or the stretch marks, never completely go away. They may fade, but they never completely go away. The return of muscle tone depends on previous tone. Occasionally, with or without overdistension because of a large fetus or multiple fetuses, the abdominal wall muscle separates, and we talked about that earlier in the term, a condition we call diastasis recti. Placental hormones. Expulsion of the placenta results in dramatic decreases of placental-produced hormones. Decreases in chorionic somatotropin, estrogens, cortisol, and the placental enzyme insulinase reverse the effects of pregnancy. Estrogen and progesterone levels drop markedly once the placenta is delivered. Pituitary hormones and ovarian function. Lactating and non-lactating women differ in timing of their first ovulation and menstruation. 70% of non-breastfeeding mothers menstruate within the first 12 weeks. And breastfeeding Women return of ovulation depends on breastfeeding patterns. Typically, your moms who solely breastfeed, they don't pump, they don't give the baby bottle, they only breastfeed. Typically, they have a slower return of their ovarian function. In non lactating women, ovulation occurs as early as 27 days after birth. The urinary system. What's important to note in the urinary system, within 12 hours of birth, women begin to lose excess tissue fluid accumulated during pregnancy. They may experience profuse diaphoresis often occurs, especially at night for the first 2 or 3 days after childbirth. Postpartum diuresis caused by decreased estrogen levels, removal of increased venous pressure in the lower extremities, and loss of the remaining pregnancy-induced increase in blood volume also aids the body in ridding itself of excess fluid. Fluid loss through perspiration and increased urinary output accounts for a weight loss of approximately 2.25 kilos during the puerperium. And typically, your mothers will complain of waking up in the middle of night drenched with sweat, or they'll complain that I get up every 30 minutes, it seems like, to use the restroom. But I like to tell the moms this is a normal occurrence. Your body's trying to get rid of the excess fluid that it accumulated over the months that you were pregnant. So postpartum diuresis is a very important thing to help rid the mom of the excess fluid that was gained throughout the pregnancy. The urethra and bladder. Excessive bleeding can occur because of displacement of the uterus if the bladder is full. So typically, in my postpartum moms, when we go to palpate the fundus, if you're trying to locate the fundus, and let's say she's 1 day postpartum, and you would expect that the fundus would be maybe 1 centimeter below the umbilicus. Well, you're palpating in that area and you don't feel the fundus, so you work your way up and you feel the fundus that is displaced to the right, is elevated in the abdomen. Typically, that's the sign that, hey, my mom has the full bladder. So what you want to do is have the mom to empty the bladder, because if the uterus is displaced, it doesn't contract as well, so moms will have more bleeding. So you want to make sure that the bladder stays empty to help with the amount of bleeding that the mom has. The appetite. So we're talking about the GI system. Most new mothers are very hungry after recovery from analgesia, anesthesia, and fatigue. So typically, if the mom was a vaginal delivery, we won't let her have any solid foods until 1 hour after the placenta has been delivered. Just in case something goes wrong, we may have to take the mom to the operating room. And then your moms who are C-sections, because they've had major abdominal surgery, we follow general surgical rules. They're ice chips, and then usually by postpartum day 1, they may let them have liquids, but we typically won't let them have whole food until the return of their bowel sounds. The bowel evacuation. Spontaneous bowel evacuation may not occur for 2 to 3 days after childbirth. Typically, our moms, after they've delivered in the postpartum area, they're typically on a Colace regimen to help with the bowel evacuation. Okay, the breast. Breastfeeding mothers, before lactation, a yellowish fluid known as colostrum can be expressed from the nipples. The breasts become fuller and heavier. We estimate that the milk lets down in 72 to 96 hours. And typically, by the time the milk comes in, the moms have already been discharged and they are home. So we do a lot of anticipatory guidance on letting them know what to do when the milk comes in. My non-breastfeeding mothers, They can experience engorgement. Even my breastfeeding moms can experience engorgement. It resolves spontaneously, and the discomfort decreases within 24 to 36 hours. For moms who are not breastfeeding, we don't want to stimulate the breast because if you stimulate the breast, they'll produce more milk. So, what we do is we tell them to wear a tight, supportive bra. We encourage ice packs. We give them mild analgesics to help relieve the discomfort. And every now and again, we may have to bind their breasts. I've had women who I've had to wrap in ACE bandages to help prevent milk production. Now, on the other hand, for our breastfeeding moms, we also tell them to wear a nice supportive lactation bra. But when their milk comes in, we don't want to stop the production of milk. So instead of telling them ice to help with engorgement, we tell them warm, like take a warm shower, which that's going to let the milk come out of the ducts and help release the discomfort from the breast milk. Now, your non-breastfeeding moms, we tell them no hot water. If they're in the shower, we tell them turn your back because you don't want to stimulate the breast. So it really depends on if the mom is breastfeeding or not. We still tell both to wear nice supportive bras, but with our non-breastfeeding moms, we don't want to stimulate the breast. We don't want the breast to produce more milk. All right, blood volume. Changes in blood volume after birth depends on several factors such as blood loss during childbirth and the amount of extravascular water mobilized and excreted. Pregnancy-induced hypervolemia allows most women to tolerate considerable blood loss during childbirth. The average blood loss for a vaginal birth of a single fetus, I know I told you this before, is 500. The typical blood loss for a woman who gave birth via C-section is 1,000 mLs. Cardiac output. It remains increased for 48 hours after birth. Cardiac output generally returns to normal by 6 weeks after birth. Stroke volume, end-diastolic volume, and systemic vascular resistance remain elevated for 12 weeks after delivery. Vital signs. Few alterations in vital signs are seen under normal circumstances. Heart rate and blood pressure return to non-pregnant levels within a few days. Blood components. The hematocrit and hemoglobin. In women with an average blood loss during birth, the hematocrit level drops moderately for 3 to 4 days, then begins to increase and reaches its non-pregnant levels by 8 weeks postpartum. White blood cell count. Normal leukocytosis of pregnancy averages approximately 12,000 during the first 10 to 12 days after childbirth. Values between 20 and 25,000 are common. Neutrophils are the most numerous white blood cells. Leukocytosis coupled with the normal increase in erythrocyte set rate that occurs can obscure the diagnosis of acute affections at this time. Your clotting factors. Clotting factors and fibrinogen are normally increased during pregnancy and remain elevated in the immediate puerperum. When combined with vessel damage and immobility, this can cause an increased risk for thromboembolism, especially after they've had a C-section because they have a period of immobility. But typically, within 12 to 24 hours, we have our C-section moms up and walking. Varicosities, there's total or nearly total regression of varicosities expected after childbirth. The neurologic system. Pregnancy-induced neurologic discomforts typically abate after birth. If the mom is complaining of a headache that requires careful assessment, postpartum headaches may be caused by gestational hypertension, stress, and leakage of cerebrospinal fluid into extradural space through the placement of a needle for epidural or spinal anesthesia. Reversal of pregnancy adaptations. Joints are completely stabilized by 6 to 8 weeks after birth. The new mother may notice a permanent increase in her shoe size thanks to her pregnancy. The integumentary system. Cloasma, or the mask of pregnancy, usually disappears at the end of pregnancy. Hyperpigmentation of the areolae and the linea nigra may not regress completely after childbirth. Some women will have a permanent darker pigmentation of those areas. Stretch marks on the breast, abdomen, and thighs may fade but do not totally disappear. Vascular abnormalities such as spider angiomas, palmar erythema, and epulis regress with rapid decline in estrogens. The spider nevi persists indefinitely for some women. Hair growth also slows during the postpartum period, and some women experience a significant hair loss after they deliver their child. The immune system. Mildly suppressed during pregnancy, the immune system returns to its pre-pregnant state. A rebound of the immune system can cause flare-ups of some conditions such as lupus or multiple sclerosis. When we're talking about the immune system, the mothers whose rubella was non-immune prior to pregnancy, we may have to give them a rubella vaccine after they deliver. Also, if the mom is Rh negative and the baby is born and the baby is Rh positive, we have to administer the RhoGAM. Now, I know I'll talk about this later, but for my moms who are rubella non-immune, we will give them a rubella vaccination after they deliver, but we have to do some education because typically after we give the mom rubella, because it is a live vaccine, we tell them they should avoid pregnancy anywhere from 1 to 3 months after the injection because it could cause some fetal malformations. Question. To provide optimum care for the postpartum woman, the nurse understands that the most common cause of subinvolution are A. Postpartum hemorrhage and infection, B. Multiple gestation and postpartum hemorrhage, C. Uterine tetany and overproduction of oxytocin, or D. Retained placental fragments and infection. You guys should have answered D. That is the correct answer. Okay, moving on. Nursing care of the family during the postpartum period, Chapter 19. In this chapter, we're going to discuss the nursing care of the woman and her family in the postpartum period extending into the 4th trimester, which is known as the first 3 months after birth. Nursing care of the postpartum woman. So components of nursing care for the mom who's delivered. We want to assist the mother with rest and recovery after birth. Assessment of physiologic and psychological adaptations to motherhood. We want to make sure we prevent complications. We want to educate regarding self-management and care of the infant. We want to support the mother and her partner during the transition to parenthood. A transfer from the recovery area. In traditional settings, the woman is moved to postpartum room after recovery, and typically recovery lasts 1 to 2 hours. Now, if the mom is in what we call an LDRP, which is labor, delivery, recovery, and postpartum, The woman and infant remain together in the room where she delivered. Post anesthesia recovery, regardless of the obstetric status, no woman should be discharged from recovery area until completely recovered from anesthesia. So, those women who have C sections, when we take them to PACU, they have to meet certain criteria to be discharged from PACU and admitted to the postpartum unit. Planning for discharge. The length of stay is dependent upon the physical condition of the mother and newborn, mental and emotional status of the newborn, the support that the mom has at home for the child, educational needs for self management, and financial constraints. Typically, for moms that deliver vaginally, the minimum amount of time they have to stay is 24 hours. So typically for a vaginal delivery, the mom can stay in the postpartum unit anywhere from 24 to 48 hours. And typically for our C-sections, 3 to 4 days, 72 to 96 hours. Some moms who've had prior C-sections and they're able to get up and walk and kind of do for themselves, the doctors sometimes will release them at the 48-hour period. They won't make them stay the 3 to 4 days. Discharge before 24 hours and after 48 hours. The terms for decreasing the length of stay of mothers and newborns after low risk birth. Typically, the early postpartum discharge. So, in your textbook, it talks about the early postpartum discharge, the shortened hospital stay, and the 1 day maternity stay. And it was saying that, moms who deliver in birthing centers sometimes can be discharged within a few hours after birth. And moms who were at low risk and their newborns were at low risk from complications can also be discharged from the hospital within 24 to 36 hours. And this short time frame is often called early postpartum discharge, shortened hospital stay, or 1 day maternity stay. This was popular in the late 80s and early 90s, but then concerns related to the health and well-being of the mothers and newborns led to legislation promoting longer hospital stays. So in 1996, the passage of the Newborns and Mothers Health Protection Act provided minimum federal standards for health plan coverage for mothers and their newborns. So under this act, all health plans are required to allow the new mother and newborn to remain in the hospital for a minimum of 48 hours after an uncomplicated vaginal birth and for 96 hours after a cesarean birth, unless the provider, along with the mother, decides that they want to leave earlier. There are some advantages and disadvantages to early postpartum discharge. For moms who had normal, healthy babies, there were no complications. It could be seen as an advantage because it can reduce their hospital costs. But for like your first time mom, sending them home so early and without us being able to educate them properly on what to look for, what to report to the physician, it can become quite problemsome. Criteria for early discharge. Um, It's recommended that the hospital stay for a mother with a healthy term newborn should be of sufficient length to identify early problems and determine that the mother and family are prepared and able to care for the neonate at home. The health of the mother and her newborn should be stable. The mother should be able and confident to provide care for her infant, and there should be adequate support systems in place and access to follow up care. Okay, now we're going to focus on the assessment of the postpartum mom. So let's start with postpartum vital signs. A slight temperature elevation is normal. If you think about it, the mom has done a lot of work with pushing and delivery of the infant. Now, if her temperature is above 100.4 after 24 hours post delivery, we start to think probable infection. But if she has a mild temperature before 24 hours delivery, we think it's probably just a normal thing with the body because of all the work of labor. The pulse, you want to report if there's an increase more than, typically we say about 120 beats per minute, because then you want to start thinking about hypovolemic shock. Respiration should be within normal limits, your normal 12 to 20. The blood pressure, typically our moms who were pre-eclamptic or eclamptic prior to delivery, we usually will monitor them for pre-eclampsia and eclampsia after delivery. And typically, if they're on magnesium, we will keep them on the magnesium for at least 24 hours after delivery. You also want to assess the mom for hypotension, especially if she's having a significant amount of blood loss. All right, so when doing our postpartum assessment, like I've told you guys before, is a normal head to toe, but we want to add the pregnancy assessment. So you're going to do your normal head to toe, but you're going to add the bubble heb. The bubble heb stands for breast, uterus, bladder, bowel, lochia, episiotomy, home and sign, emotional status, and bonding. So with the breast, we want to know if the mom is breast or bottle feeding, whether her nipples are inverted, everted. Make sure that her breasts are not hard. They should still be soft because the milk shouldn't have come in as of yet. Then we're going to do the uterus. You want to see where the fundus is, and we talked about involution. So remember, you want to know, depending on what day she is postpartum, you should be able to tell where the fundus should be located. The bladder, like I said earlier, we want to make sure that we keep the bladder empty, because if the bladder is full, it could displace the uterus up and to the right, and then the mom will be at risk of bleeding. The bowel, it used to be a time we made all moms, they had to have that bowel movement before they went home, but we don't do that anymore. Typically, our moms are on a colace regimen after they deliver. The lochia, typically, while she's in the hospital, she's still going to have the lochia rubra, but we need to teach the mom that you're going to have other phases of the lochia. So we have to teach her about the lochia serosa, the lochia alba, and let her know when she needs to call the physician if the lochia gets a bad smell or foul smell, if she reverts back to lochia rubra, anything like that. Then E is your episiotomy or perineal lacerations. Like I said, those typically heal pretty fast. So when you're doing your postpartum assessment, you turn the mom to her side. That way you can look at her pad for her lochia, and you can also look at her bottom to see if her episiotomy or lacerations are healing well. One thing that I like to do after my mom has delivered, and even if she didn't tear or have an episiotomy cut, I like to put ice on the perineum, and that just helps with the swelling and the discomfort that comes with after having the baby vaginally. Now, your Homan sign, we're checking for DVT. Typically, we don't do Homan sign, because if we do that and there is a clot, we could possibly dislodge that clot. So we don't perform Homan sign. But what we do in our assessment is we look for swelling, heat, warmth and we palpate and ask the mom if she's having pain anywhere in her calves. We definitely want to look at the emotional status of the mom. Is she happy? Is she sad? Is she crying? What's the emotional state of the mom? And we also, we as postpartum nurses, they have to document if there's bonding happening between the mom and the baby, and also the father or the significant other in the baby if they are present. Okay, promoting safety by preventing hemorrhage. One of the things we want to do, and I'm saying this quite a bit, so it might be important, you want to make sure you keep the bladder empty. And this picture over here shows you if the bladder is full, it will displace the uterus up and to the right. You want to assess for risk factors. Moms who've had twins, triplets, anything that overdistends the uterus, polyhydramnios, macrosomic, these moms are going to be more prone to having problems with bleeding afterwards. Typically, whenever we do our assessment, we always want to massage the fundus as needed. I usually will teach my moms how to massage their own fundus, and usually I'll let them palpate their fundus. I'll tell them, you feel it? It should feel like a hard softball. And I usually will tell them every hour I want you to rub your tummy until you feel that hard softball. And I tell them, if you do this every hour, when I come in every 2 to 4 hours to rub it, I won't have to rub it as hard. Because it should be nice and firm. We want to always make sure that the fundus is firm, because if the fundus is not firm, the mom will bleed. So you're going to hear the term boggy. And I like to say, if the uterus is boggy, the mama is bleeding. So you want to always, if you encounter a boggy uterus, you want to massage it. Also, Pitocin can be ordered typically after they deliver. I usually like to give the mom at least a liter, maybe 2 liters of IV fluid with Pitocin already in the bag. Other medications that we use, I don't know if I'm kind of getting ahead of myself, but I like to talk about the 4 different medications we use for postpartum hemorrhage. And those meds are Methergin, Hemobate, Cytotec, and Pitocin. And I'll probably talk about those a little bit later in the audio lecture. All right, promoting comfort. We can ice the perineum if the perineum is swollen or edematous. Sitz baths, and this is a picture of a sitz bath. And basically, you put warm water and you have it hanging in a bag, and you open up the clamp and it just kind of washes the perineum with the warm water. This is very soothing for the postpartum moms. We also teach them good perineal care, and like I said, they'll get their plastic bottle. We tell them fill it with warm water. You want to squirt from front to back. Then you're going to take your tissue and you're going to pat the perineum dry. I don't want them rubbing the perineum, especially if they've had an episiotomy or a laceration. And definitely some pain control measures. Typically, if they've had a vaginal delivery, you'll see them on usually ibuprofen. Sometimes, especially moms who've had more babies and they have the severe afterbirth pains, we may give them some Percocet. Now, your moms who've had C-sections, they're going to require a bit more medication, and sometimes they're on PCAs for the first 12 to 24 hours after delivery, and then we change them over to some oral pain medications. Okay, promoting elimination. Like I said, for bowel, we make sure that they have their colace if they're constipated. But typically, you usually get the constipation with moms who've had C-sections because you know that surgery, it kind of slows the intestines down. But typically, we have moms on colace to help with bowel elimination. Bladder elimination. I know we talked earlier about the postpartum diuresis. So when they're having all that extra urinary output, their chances of getting a UTI increases. So we definitely have to teach them good perineal care when it comes to preventing UTIs. Uh, Also, you'll have some topical anesthetics and analgesics. These are the Tux pads. These are the pads that we use if the moms have hemorrhoids. I like the Tux pads. What I do is I just line the pad with the Tux, and it just has like this cool feeling along the perineum, and a lot of women like that. We also have the dermoplast, and this is just an anesthetic spray. You spray it on the perineum and it kind of gives a little numbness to the perineum. All right, promoting successful infant feedings. If our moms are bottle feeding, we want to do what we call lactation suppression. We want to disencourage the milk from it's going to come in, but we want to disencourage the body from making more milk. So typically with our bottle feeding mamas, we tell them do not stimulate the breast. We tell them to wear a nice, tight, supportive bra. Once the milk comes in, we tell them to ice it down because engorgement is very painful. So I'll tell my moms to take like the freezer bags of peas or carrots and just put them on their breast to help with the pain and discomfort of engorgement. Another thing we tell moms is cabbage leaves, and that's known to help stop the breast milk production. So tight bra, no stimulating the breast, cabbage leaves, and I tell them when they're taking their showers, make sure their backs are turned to the water. I don't want that warm water hitting the breast because that's going to stimulate the breast to produce more milk. Now, my breastfeeding moms, I want to make sure that milk production continues. So with the breastfeeding moms, we still tell them to wear a supportive bra, a nursing bra. When they have issues with engorgement, some of the things we tell them to do is to take a warm shower. We can tell them to breastfeed the baby, or we can tell them to pump to kind of alleviate the discomfort of all the excess milk. Typically, we teach them nursing on demand. Typically, even moms that are bottle feeding, we kind of put them on a regimen of about every 3 to 4 hours for feeding the infant. Promoting maternal well-being. You definitely want to encourage rest and a gradual return to activity. I like to tell my new moms in the beginning, if the baby is sleeping, you should be trying to sleep and nap also. It's easy in the hospital because you have support there. And if I have a mom who's struggling, sometimes at night I will take the baby either to the nursery or to the nurse's station in order for the mom to get a good night's sleep. Definitely, we want to encourage adequate nutrition because moms who are breastfeeding, they need the extra calories to help support the breastfeeding. And we want to teach the mom the warning signs to report to the doctor, such as uh, increased temperature, increased bleeding, uh, anything that seems to be abnormal, we need to teach them the warning signs of when to call their physician. Postpartum vaccinations. We talked a little bit about the rubella vaccination. If the woman is not immune, vaccination is recommended. And like I said earlier, you must tell the woman she should not get pregnant from anywhere from 1 month to 3 months after receiving the rubella vaccination. Varicella, the CDC recommends the administration of varicella vaccine before discharge for postpartum women who have no immunity. A second dose is given 4 to 8 weeks after the first dose, and usually they'll get this dose at their follow-up visit. Tetanus, diphtheria, pertussis, or your Tdap vaccine is recommended for postpartum women who have not previously received the vaccine. It is given before hospital discharge or as early as possible in the postpartum period to protect women from pertussis and decrease the risk of the infant's exposure to pertussis. RH iso immunization. Your RH immune globulin or your RhoGAM should be given within 72 hours for RH negative women who deliver an RH positive infant. Nursing care management of psychosocial needs. Meeting the psychosocial needs of new parents involves assessing their reactions to the birth experience, their feelings about themselves, and their interactions with the new baby and other family members. Specific interventions are then planned to increase the parents' knowledge and self-confidence as they assume the care and responsibility of the new baby and integrate the new baby into their family. You can read in your textbook. I'm not really going to emphasize these things. Read over the section that talks about the impact of the birth experience, the maternal self-image, adaptations to parenthood and parent-infant interactions, family structure and functioning, and impact of cultural diversity. Discharge teaching. The nurse functions primarily as teacher, encourager, and supporter while implementing the psychosocial plan of care for a postpartum woman. Self-management and signs of complications. In your textbook, Table 19-1 and Box 19-2 list several common indications of maternal physical and psychosocial problems in the postpartum period. So before discharge, the woman needs basic instructions regarding a variety of self-management topics such as nutrition, exercise, family planning, the resumption of sexual intercourse, prescribed medications, and routine mother-baby follow-up. All right, sexual activity and contraception. Typically, for the resumption of sexual activity, we tell the couple to wait until the 6-week postpartum checkup. However, not all couples follow that rule. So as the nurse, you can advise them. That's what we recommend because, it takes a few weeks for the perineum and the vagina to recover from the trauma of birth. Typically, contraception, we start talking about contraception during the prenatal visit. So typically, by the time of discharge, the mom knows what type of contraception she's going to be on or whether or not she's not going to be on any contraception. We give them a list of their prescribed medications and what they're for. Typically, for a vaginal delivery, they're going home on their prenatal vitamins. We tell them they can still take their prenatal vitamins, their Colace, and their iron. And if they're C-sections, they're still doing the prenatal vitamin, Colace, iron, and then any pain medications that they're prescribed. Typically, your routine mother and baby checkups. Typically, the mom usually returns at 6 weeks for vaginal birth, and usually for a C-section, some physicians have them come in twice. They may have them come in at 2 weeks after the C-section, and then again 6 to 8 weeks after the surgery. And typically, the pediatrician would want to see the newborn baby 48 to 72 hours after discharge. It kind of depends. Usually they want to see the breastfeeding babies a little bit sooner to make sure that they're getting adequate nutrition. Okay, follow up after discharge. Your book talks about home visits, telephone and follow up calls, warm lines, support groups, or referral to community resources. You can briefly look over those. Don't put too much thought into them. Question. Childbirth may result in injuries to the vagina and uterus. Pelvic floor exercises, also known as Kegel exercises, will help to strengthen the perineum muscles and encourage healing. The nurse knows that the client understands the correct process for completing these conditioning exercises when she reports, A, I contract my thighs, buttocks, and abdomen. B, I do 10 of these exercises every day. C, I stand while practicing this new exercise routine. Or D, I pretend that I am trying to stop the flow of urine midstream. Now, girls, all of you should get this answer right. The correct answer is D. Chapter 20, Transition to Parenthood. Becoming a parent creates a period of change and instability for men and women who decide to have children. This period occurs whether parenthood is biologic or adoptive, and whether the parents are married, husband-wife couples, cohabiting couples, single mothers, single fathers, lesbian couples with one woman as biologic mother, or gay male couples to adopt a child. Parenting is a process of role attainment and role transition. The transition is an ongoing process as the parents and infant develop and change. Parental attachment, bonding, and acquaintance. The process by which a parent comes to love and accept a child, and a child comes to love and accept a parent, is known as attachment. Using the terms attachment and bonding, originally proposed that there is a sensitive period during the first few minutes or hours after birth when mothers and fathers must have close contact with their infant to optimize the child's later development. Attachment is developed and maintained by proximity and interaction with the infant, through which the parent becomes acquainted with the infant, identifies the infant as an individual, and claims the infant as a member of the family. The concept of attachment includes mutuality, that is, the infant's behaviors and characteristics elicit a corresponding set of maternal behaviors and characteristics. An important part of attachment is acquaintance. Parents use eye contact, touching, talking, and exploring to become acquainted with their infant during the immediate postpartum period. Nursing interventions to facilitate parental attachment are numerous and varied. Table 20-3 in your textbook talks about some of these. Assessment of attaching behaviors. One of the most important areas of assessment is careful observation of specific behaviors thought to indicate the formation of emotional bonds between the newborn and family, especially the mother. Unlike physical assessment of the neonate, which has concrete guidelines to follow, assessment of parent-infant attachment relies more on skillful observation and interviewing. Rooming in of mother and infant and liberal visiting privileges for father or partner, siblings, and grandparents provide nurses with excellent opportunities to observe interactions and identify behaviors that demonstrate positive or negative attachment. Parent-infant contact. Early close contact may facilitate the attachment process between parent and child. Early skin-to-skin contact between the mother and the newborn immediately after birth and during the first hour facilitates maternal, affectionate, and attachment behaviors. Extended contact. Rooming in is common in family-centered care. With this practice, the infant stays in the room with the mother. In some facilities, the newborn never leaves the mother's presence. Nurses perform the initial and ongoing assessments and care in the room with the parents. In other hospitals, the infant is transferred to the postpartum or mother-baby unit from the transitional nursery after showing satisfactory extrauterine adjustment. Extended contact with the infant should be available for all parents, but especially for those at risk for parenting inadequacies, such as adolescents and low-income women. Postpartum nurses need to consider and encourage activities that optimize family-centered care. Baby-friendly status for a hospital is one means to promote family-centered care. And with baby-friendly, that's basically where the moms and the babies are never separated. They encourage maternal and fetal attachment and bonding through skin to skin and breastfeeding and things like that. The senses. Touch or the tactile sense is used extensively by parents as a means of becoming acquainted with the newborns. Eye contact is also very important when talking with the newborns and the interaction between the mom and the father. As newborns become functionally able to sustain eye contact with their parents, they spend time in mutual gazing, often in the in-face position. In this position, the parent's face and the infant's face are approximately 8 inches apart and on the same plane. Dimming the lights encourages the infants to open their eyes. To promote eye contact, installation of the eye ointment can be delayed until the infant and parents have had some time together. And typically, we don't put the eye ointment in until after the first hour of life. Voice. The shared responses of parents and infants to each other's voices is remarkable. Parents wait tensely for the first cry. Once that cry has reassured them of the baby's health, they begin comforting behaviors. Odor is another behavior shared by parents and infants. They respond to each other's odors. The moms know how the baby smells. The baby knows the smell of their mom and can distinguish the odor of their mother's breast milk. Entrainment. Newborns move in time with the structure of adult speech, which is termed entrainment. They wave their arms, lift their heads, and kick their legs, seemingly dancing in tune to a parent's voice. Biorhythmicity. The fetus is in tune with the mother's natural rhythms. Biorhythmicity, such as her heartbeat, after birth, the mother's heartbeat, or recording of a heartbeat, can actually soothe a crying infant. The more quickly parents become competent in child care activities, the more quickly they can direct their psychologic energy towards observing the communication cues the infant gives them. Reciprocity is a type of body movement or behavior that provides the observer with cues. The observer or receiver interprets these cues and responds to them. Reciprocity often takes several weeks to develop with a new baby. Parental role after childbirth. What I want you guys to know on this slide is let's look at the becoming a mother. Rubin identified three phases of maternal role attainment in which the mother adjusts to her parental role. These phases extend over the first several weeks and are characterized by dependent behavior, dependent independent behavior, and interdependent behavior. Table 20-4 in your textbook goes over these phases, the taking in phase, the taking hold phase, and the letting go phase. Make sure you read over this table and kind of know what happens in each of these phases. Postpartum blues. The pink period surrounding the first day or two after birth, characterized by heightened joy and feelings of well-being, is often followed by a blue period. Up to 80% of women of all ethnic and racial groups experience the postpartum blues or baby blues. During the blues, women are emotionally labile and often cry easily for no apparent reason. This lability seems to peak around the 5th day and subside by the 10th day. Other symptoms of postpartum blues include depression, a letdown feeling, restlessness, fatigue, insomnia, headache, anxiety, sadness, and anger. Biochemical, psychologic, social, and cultural factors have been explored as possible causes of the postpartum depressive state. However, the etiology remains unknown. We will go into more detail on the postpartum psychological disorders in the next chapter, chapter 21, the complications. You can read over in your book the topic of becoming a father, the different relationship that the father develops with the infant, and then know what engrossment is. Adjustment for the couple resuming sexual intimacy with a newborn in the house that can pose some problems. Infant parent adjustment. Infant parent adjustment. Infant parent interactions can be facilitated in at least three ways. 1, the modulation of rhythm. 2, modification of behavioral repertoires, and 3, mutual responsivity. Nurses can teach parents about these three aspects of infant-parent interaction through discussion, written materials, and video recordings describing the infant's capabilities. Rhythm. To modulate rhythm, both parent and infant must be able to interact. Therefore, the infant must be in the quiet alert state, one of the most difficult of the sleep-wake states to maintain. The alert state occurs most often during a feeding or in face-to-face play. The parent must work hard to help the infant maintain the alert state long enough and often enough for interactions to take place. The in-face position is usually assumed. With maturity, the infants can sustain longer interactions by modulating activity rhythms. Meanwhile, the parent becomes more attuned to the infant's rhythm and learns to modulate the rhythms, facilitating a rhythmic turn-taking interaction. Behavioral repertoires. Both the infant and the parent have a repertoire of behaviors they can use to facilitate interactions. Fathers and mothers engage in these behaviors depending on the extent of contact and caregiving of the infants. The infant's behavioral repertoire includes gazing, vocalizing, and facial expressions. The infant is able to focus and follow the human face from birth and is able to alternate the gaze voluntarily, looking away from the parent's face when understimulated or overstimulated. Body gestures form a part of the infant's early language. Babies greet parents with waving hands or reaching out of hands. They can raise an eyebrow or soften their expression to elicit loving attention. Responsivity are those that occur within a specific time and are similar in form to a stimulus behavior. The adult has the feeling of having an influence on the interaction. Infant behaviors such as smiling, cooing, and sustained eye contact, usually in the in-face position, are viewed as contingent responses. This is figure 20-8 in your textbook, holding the newborn in in-face position. Diversity in transitions to parenthood. Various factors including age, social networks, socioeconomic conditions, and personal aspirations for the future influence how parents respond to the birth of a child. Cultural beliefs and practices also affect parenting behaviors. Factors that influence the risk for parenting problems include age, whether they're an adolescent or they're older than 35, same-sex parenting, social support, culture, socioeconomic conditions, and personal aspirations. The visually impaired parent. Visual impairment alone does not seem to have a negative effect on parents' early parenting experiences. These parents, just as sighted parents, express the wonders of parenthood and encourage other visually impaired persons to become parents. There's a heightened sensitivity to other sensory outputs. Infants will need sensory input from the other parent if they have one parent who's visually impaired. For the hearing impaired parent, a parent who has a hearing impairment faces challenges in caregiving and parenting, particularly if the deafness dates from birth or early childhood. Whether one or both parents are hearing impaired, they are likely to have established an independent household. Devices that transform sound into light flashes can be fitted into the infant's room to permit immediate detection of crying. Sibling adaptation. Siblings have to assume new positions within the family hierarchy. Their reactions to the newborn baby can be manifested in behavioral changes. You want to involve the siblings in planning and care of the new baby as much as possible. Grandparent adaptation is most often associated with joy. They may feel regret due to poor health or geographical distance. Grandparents are eager to help. The maternal grandmother is called on the most. There can be intergenerational relationships and shifts, and involvement is dependent on cultural and other familiar factors. Nursing care is directed toward helping the parents cope with infant care, helping them through the role changes of becoming parents, help them with the altered lifestyle that bringing a new baby into the family changes everything, the change in the family structure due to a new baby, and definitely we have to give some anticipatory guidance, teach them on things that they should expect once they are discharged from the hospital. Question: a 30-year-old multiparous woman has a boy who is 2.5 years old and now an infant girl. She tells the nurse, "I don't know how I'll ever manage both children when I get home." Which suggestion would best help this woman alleviate sibling rivalry? A. Tell the older child that he is a big boy now and should love his new sister. B. Let the older child stay with his grandparents for the first 6 weeks to allow him to adjust to the newborn. C. Ask friends and relatives not to bring gifts to the older sibling because you do not want to spoil him. D. Realize that the regression in habits and behaviors in the older child is typical reaction and that he needs extra love and attention at this time. Now, if you answered anything other than D, your therapeutic communication skills need some improvement. So the answer to this question is D.